Good afternoon, everybody. Um, it's 2 minutes past 4. I see we already have 92 participants. We are on to 93 now. So I think I will start. So for those who don't know me, I'm Dr. Charlene Parasnath. I'm the head of Department of Clinical Hematology at the University of KwaZulu-Natal. And I'm actually the head clinical unit of the Clinical Hematology Unit at Albert Lutuli. And today we will be presenting some cases that we've seen recently, which were quite interesting, and we thought we would share with you. And my colleague and fellow, Dr. Jasmine Ramia, will be co-presenting with me today. So she'll be doing predominantly all the talking, and I just will be doing a few, uh, two cases. So before we get on to that, there is some housekeeping rules. So for those of you who have not been on this platform previously, our recordings are recorded and can be found. I'm just wondering whether I am, no, I am unmuted. So, our these recordings can be found on the Blood Assay website. And sorry, I don't know if I have control of this. Just sorry, excuse me.
It was just me, Charlene.
Are we live at the moment? Can you hear me?
Yes, we can, sure.
Yeah, we can hear you.
Oh, okay. Sorry, I thought I was speaking to myself all along. So, sorry. So, for those of you who have not been here previously, um, all these recordings can actually be found on the Blood Essay website. And if you actually are not registered and have not been receiving emails, please contact the Blood Assay team, and you will be uploaded onto the database to be invited for these. So CPD points are submitted to the HPCSA for South African attendees. So please enter your details correctly when you are registering, and ensure that your HPCSA number is entered correctly as stated in the when you are registering. You will see it says upcase with the space, etc. So please ensure that's done correctly so that you get your point. In addition, you have to attend for at least an hour in order to get your points. So the next, so your mailing list, you can join the mailing list via the website. And I'd like to introduce you to the deep dive management team who have been running this program so well for the past few years, and has actually been amazing at what they do. So it's Prof. Stelfer Berg, who is the deep dive team leader, and Dr. Ferdinand Kritzinger, who is the national training coordinator, and Nicola Smith, the national outreach officer. So please do contact Herdine and Nicola if you have any queries as well. So I think that's the last slide. So our topic this week is based on two cases with myelodysplastic changes in young acute myeloid leukemia patients. So I will start sharing my, let me sharing this. So this is our agenda. I'll be presenting the two cases, and then Jasmine will be presenting, do a little bit of a deep dive into this. And Jasmine, just as an introduction, Dr. Jasmine Ramia is a fellow in my unit. She started her training in December last year. She is a hematopathologist and has worked initially as a medical officer for a number of years in our unit and went on to specialize further in hematopathology, and now has come full circle and has joined us in training in our unit. So I'm glad that she's with us with her experience and yeah, so she's also an associate. She's not actually associate, like she is a lecturer at the university, and she's part of the yeah, of our team. And so I'm going to actually stop sharing. Can I share my slides now?
Yeah, sure.
Okay.
I'm just gonna hang on one sec. I'm just gonna stop sharing.
Okay. Thank you. Thanks, Yardeen. So I've entitled mine Shadows of Dysplasia, Unmasking AML with MDS-related changes. I'll try not to spend too much time on these because Jasmine has the meat of what we need to discuss today. Sorry, the slides are not advancing. Okay, so the first case that we have, let me just minimize this. Sorry, I've done something to my screen. You know what I've done here? I'm so sorry, guys. What I've done with my book. I'm here with my screen. Okay, sorry, can you see my slides now?
Yes, and
Yes.
it's advancing nicely.
Okay, sorry about that. So our first case is, I think, let me just stop sharing my video. It's not. Oh, anyway, I will stay on this. An 18-year-old female, para 1, referred from our sister hospital down the road from us. That's where our other clinical hematology unit is. And she was referred as a suspected acute leukemia, but via the obstetric unit. So she was a first-year consumer science student at the Technicon with no known allergies and no significant family history, no previous use of recreational drugs, alcohol, or smoking. So she was initially referred to um, a VMH from her local clinic because she was found to be anemic during her routine antenatal clinic. So her booking HB was 8.5. And patient actually complained about intermittent dizziness for about a month. So on arrival at BMH, she was seen at the obstetric unit and received 2 units of red cells. and then discussed with the high care obstetric unit at our hospital. A little bit on her past medical history, which we found when she actually arrived at our hospital, was that at age 4, she was actually seen at the ped hematology unit, 4 years, 11 months, and with a problem of thrombocytopenia of uncertain cause. And at that point was suspected that she had ITP. The bone marrow had no obvious infiltrate. The megs were increased. He seemed to have been lost to follow-up after initial steroid treatment. So on arrival at our hospital on the 7th of November last year, she was found to have a hemoglobin of 5.8, platelets of 40, and a white cell count of 2.12. Peripheral smear showed 13% blast, abnormal morphology, suspicious for an acute leukemia. She had a normal kidney and liver function. Her viral screen showed that she had the CMV, IgG, and IgM positivity, and HIV, hepatitis B and C were negative. And these were her iron studies and B12 and folate. So on clinical examination, she was an ECOG-1. She had conjunctival and palmar pallor, lymph nodes, right submandibular, mobile, non-tender, and mild pitting edema bilaterally. Her clinical exam, aside from her gravid uterus, there was pretty much a normal clinical examination, difficult to palpate for any organomegaly at the time. On the day we saw her, when the consult was sent to us, she had an HB of 7.3 and a white cell count of 2.17. And at that point, the lab was suspecting an acute myeloid leukemia based on the morphology. So she was admitted to the labor ward high care in isolation, and they instituted neutropenic precautions. She was commenced on IV fluids, allopurinol, and folic acid, and transfusion triggers were set in consultation with us. And then we went on to plan for a bone marrow aspirate and trephine, and had a multidisciplinary team meeting with the obstetrics department, the anesthetics team, and the neonatologist in order to plan forward for this patient. So on the 9th of December, was meant to be 2024, a bone marrow aspirate and trephine was performed. On the day of the bone marrow, again, the HB was 9, platelets was 37, and she had a low white cell count and 28% blast. So the aspirate showed hyper to normal cellular particles with megakaryocyte dysplasia. They noted to be some micromegakaryocytes, and the megakaryocyte showed nuclear dysplasia as evidenced on this picture, which was shared with us by our lab colleagues. And so these are some of the features that were actually, this arrow actually moved, but this picture here shows some of the megakaryocyte dysplasia, and then the next one, shows some of the erythroid dysplasia as well, with the multinucleate forms, and there's some increased RE activity. You can see the cells are being engulfed by this macrophage. So these were the features. There was some erythroid changes as well, with nuclear cytoplasmic asynchrony, and yeah. So these were some of the images of the patient's bone marrow illustrating the dysplasia. And on flow cytometry, which was done, these are some of the flow plots. So she showed positivity for CD34, for 117, HLA-DR, CD15, and important negative markers, which Jasmine will touch on, was the CD9, CD7, 61, TDT were negative. And so her progress in the ward was, we then decided, she was early on in her pregnancy, and the decision was made that we would offer some supportive care whilst having started her on steroids to mature the baby's lungs. And so it took us about, I think, about 2 weeks from the time she first came till the decision to do the elective Caesar on the 27th of November. Her pre-op bloods, she had an HB of 8.8, platelets of 25, and her white cell count had gone up to 4.43, and the procedure was done under platelet cover. She delivered a live male baby at 1.99 kilograms, and the APGARs were 5 and 10. So subsequent to that, we then received back the molecular studies that were done on her on the bone marrow a few weeks before, and she found to have the T69 translocation or the DEC NUP214. So she was eventually then signed out as an AML with translocation T69. She went on then to receive standard induction with 3+7 from the 4th of December to the 10th of December. And post-induction, her bone marrow showed 5% MRD on actual morphology. We then decided to re-induce her with FLAG. However, post-FLAG, she had 5% morphological blast and 0.85% on flow. And although there was a matched sibling donor available, the patient was counseled and given the option for further chemotherapy. Unfortunately, the best we had was HiDAC and MITRA, or to give her further FLAG. So eventually the patient and her mom opted for palliation. So just some thoughts on this case, which this patient actually did not have, but perhaps, I mean, many people may not know about the congenital amegakaryocytic thrombocytopenia, which may actually can lead to MDS or AML later on in life. So unfortunately, this was not the problem that she initially presented with when she was 4 years old was not further followed up due to the fact that she defaulted. However, it's important to remember that congenital amegakaryocytic thrombocytopenia, which is due to the mutations in the CMPL gene, affects thrombopoietin receptor function, and patients then present with severe thrombocytopenia from birth and often may progress to pancytopenia, MDS, or AML. So that was just something, by the way, that I thought I would mention, which we actually didn't confirm in our case. So I just need to make a disclaimer there. Then our second case, also a young girl, young lady, she was 19 years old, RBD negative, para-1, and she was referred from Stanger Hospital, which is up the north coast from us, and she was 30 weeks pregnant as well, and her presenting symptoms was epistaxis, bleeding gums, generalized fatigue, and constitutional symptoms for about a week, and she also reported recurrent perianal and oral ulcers. She is a grade 10 scholar and had no previous history of any medical conditions and no family history of blood cancers or other cancers or blood disorders. And these were she presented with the pancytopenia with, actually there's quite a few nucleated red cells as well in her peripheral smear. So that prompted her to be referred on. And when she was examined by us on the 6th of December, this was her clinical finding. So she had conjunctival pallor and palmopallor, some shotty lymph nodes, but significant gum hypertrophy as evidence in this picture. Her clinical examination revealed obviously a gravid uterus, and she had a ulcer in the anal cleft, which was quite big, and this has some significance later on. So her viral screen, some of the investigations we've done at baseline showed that she was a hepatitis B negative and hepatitis C negative. However, her EBV IgM was positive with a viral load of 247. And interestingly, she was also found to have a low vitamin B12 level. And ultrasound imaging showed that she had a enlarged liver and a spleen that was slightly enlarged at 12.6 centimeters, and interestingly, an ectopic left kidney with bilateral hydronephrosis and hydroureter. Echo showed that she had an ejection fraction of 75% with a small pericardial effusion. So these were the findings on her flow cytometry. So she had 22.2% myeloid blasts, which were CD34 positive, HLA-DR positive, 117, MPO 1333 and 123, and did not express any other aberrant markers and expressed CD9. So her bone marrow aspirate and tryptophan, so her HB platelets and white cells were low at the time, and as you can see, she had quite a significant amount of nucleated red cells, and the aspirate and tryptophan done on the 6th of December showed a tryptophan which was variably cellular with normal to hypercellular particles. Trilineage hemopoiesis was underrepresented due to a pleomorphic infiltrative blast. I do not have images for this patient, and as well as on the trephine, it showed that she had single cell streaming and dilated sinus as suggestive increased fibrosis. The aspirate showed these dysplastic micromegakaryocytes with nuclear separation, and the erythropoiesis showed megaloblastic changes, nuclear to cytoplasmic asynchrony as in the other patient. Some were multinuclear, and the granulopoiesis was underrepresented. And the population of blasts described was the pleomorphic, medium-sized basophilic cytoplasm. So again, with this case, we held a multidisciplinary team meeting with the anesthetics, neonatologists, sorry, I meant to say the obstetricians, and the family was counseled. And during this time, the patient actually cultured a multi-drug resistant Acinetobacter on the 13th of December and was commenced on colistin. On the 19th of December, she underwent a cesarean section at 32 weeks, also having had steroids to mature the baby's lungs. And she delivered a live male baby at 1.77 kilos. These were the APGARs at 1, 5, and 10 minutes. So we then decided to start her on 3+7, the standard protocol. However, on the 17th of January, we received back her NGS results, and it showed the RUNX1 with possible germline mutation. Then she had the U2AF1 B core stag. So she had all of these mutations on her NGS. Her post-induction marrow showed 1.53% normal blast, and lack of aberrant markers made it difficult for them to assess the presence of MRD on flow. So she went on to receive thereafter her first consolidation with HiDAC. And this is just the picture of her NGS results, and it just shows that she has all these quite significant mutations, and 50% of the RUNX, the variant allele frequency of RUNX1 was actually 50%, raising the possibility of a germline variant. So the final report was signed off as AML with myelodysplastic related changes, and to exclude germline predisposition, a myeloid neoplasm with a germline predisposition. The challenge with her is she has been having recurrent UTIs, multi-drug resistant organisms. So in summary here, we have an AML with MDS-related mutations, which was diagnosed during pregnancy. She had an ectopic left kidney with bilateral hydronephrosis and hydroureter, vitamin B12 deficiency, and post-induction and HIDAC1 showed no MRD. Of concern, though, is this possible germline mutation, and his sibling has been swabbed for HLA typing. However, our concern remains if this actually is a germline mutation and whether we should actually consider a matched unrelated transplant for her, seeing that she is a high-risk AML. And so just some final thoughts again here. This patient has an ectopic kidney, and whether she may have some underlying, Fanconi is unlikely because she does not have any features to suggest it. But to bear in mind, conditions like that actually can predispose you to develop hematological malignancies. So I would like to thank the Department of Hematology, the NHLS at our university, Dr. Rapiti, Dr. Murugan Morthy, and Ms. Ismail for sharing some of the images. And I think I will hand over to Jasmine, and then perhaps we can take the discussion afterwards once she's told you more about our cases. So thank you. I'll hand over to you, Jasmine.
Thanks, Charlene. Just confirming you can see my screen.
Yes, we can.
Okay, and if I'm audible.
Yes, you are.
Okay, good afternoon, colleagues, and thank you to Charlene. Thank you to Blood SA for this opportunity. So as Charlene did mention, my name is Dr. Jasmine Ramia, and I'm one of the newest clinical hematology fellows at Nkosi Albert Luthuli Hospital in Durban. And today I'm presenting a genetic time bomb, World War V, the implosion of AML myelodysplasia related. The aim of my discussion today is to lay siege to AML myelodysplasia related, really exonerating the molecular implications which contribute towards this war of theranostics. Okay, so in terms of refining and defining, AML myelodysplasia related was first introduced in 2008 into the WHO classification, and since then has had several nomenclature alterations. So initially was AML myelodysplasia related changes, and now is AML myelodysplasia related, but essentially has more than 20% bone marrow blasts noted in the bone marrow or the peripheral blood. And the subcategories is that to maintain or rather entertain this diagnosis, one needs to have features of dysplasia in more than 50% of greater than 2 myeloid lineages. Now, this particular subcategory has been removed from the WHO-5. One must also have a prior history of MDS or MDS-MPN overlap, and this is a qualifier in terms of the ICC classification. In terms of MDS-related cytogenetics and mutations, the ICC recognizes 9 mutations that have a 95% specificity for AML myelodysplasia related. And these include, for example, the cell signaling, epigenetic or spliceosome, and the cohesion complex. And later on, I'm going to be discussing those as well. And then is further refined in 2016 to exclude NPM1 or biallelic SEPA, as well as a deletion 9q has been removed. The proviso is that one must not meet criteria for therapy-related AML or AML defined by genetic abnormalities. So how do we entertain a diagnosis of AML comparing the WH5 and the ICC? In terms of the ICC, there is a hierarchical categorization. One would commence with AML with recurrent genetic abnormalities, then progressing to mutated TP53 with a variant allele frequency of 10%, and then myelodysplasia gene mutations takes preference over myelodysplasia-related cytogenetic abnormalities. And then, of course, lastly, is AML not otherwise specified. So if one has the diagnosis of AML myelodysplasia-related, comparatively looking at the WH5 and ICC, there are modest differences between the cytogenetics and the somatic mutations. With reference to the cytogenetics, the WHO5 mentions del11q as well as deletion 13q, whereas the ICC would focus on the addition of 5q, trisomy 8, and del20q. Interestingly, RUNX1 seems to have a lot of attention in the ICC. It is MDS defining, and this has been excluded in the WH5. Once again, having a history, a preceding history of MDS or MDS-MPN overlap is a qualifier in the ICC, and this is not noted in the WH5. So where did our patients fall? So both of our patients initially were classified as AML myelodysplasia related. However, after refinements in the classification with the addition of molecular diagnostics, case 1 was defined as AML with genetic abnormalities, and this was the case of DECNUP214 or translocation 69. And then case 2 with the RUNX1 variant allele frequency of more than 50% was termed a myeloid neoplasm associated with the germline predisposition. So what is the significance of the further refinements? Well, both according to the ELN classification of 2022 have an adverse prognostication. However, there is a therapeutic significance, as Charlene did allude to. Case 2, we would not perform a match-related allogeneic stem cell transplant, but rather a matched unrelated in view of the germline predisposition. So just to digress with regards to case 2, looking at the genetic time bomb, myeloid neoplasms with a germline predisposition. So in case 2, there was a RUNX1 mutation, approximately about 50%, suggesting germline. Just a little bit about RUNX1. The mutation is noted in exon 3 to 8, and this is the DNA binding domain. It occurs in the young and has a familial predisposition. It's autosomal dominant. So they will have a strong familial history. They have a lifelong bleeding tendency. And interestingly, in this case, she maintained adequate hemostasis post-cesarean section, so therefore not warranting further investigation for a platelet dysfunctional disorder. The transformation risk occurs as a result of the somatic mutations, the adverse somatic mutations. So that would be ASXL, FLT3, and TET2. And how we would test for germline is to either do a fibroblastic skin analysis or a buccal swab, employing the techniques of whole genomic sequencing or targeted panels. With respect to treatment, we would want to perform a matched unrelated donor allogeneic stem cell transplant, but other therapies include FLT3 inhibitors, IDH1 and 2, BCL2 inhibitors, hypomethylating agents, coupled with genetic counseling of the first-degree relatives. So time to ignite the discussion with a focus on AML myelodysplasia related. It is a ticking time bomb. In terms of the epidemiological data, noted to be found in the elderly with a median age of between 71 to 73 years, is more common in males and uncommon in childhood. And interestingly, this is contrasting to both of our cases who were young females. The incidence is about 25 to 48% of all AML, and later on we're going to look at the South African perspective as well. So is there exclusivity of age? And the answer is no. In the pediatric cohort, the incidence is about 21% of all pediatric AML, with an incidence that decreases with age. So in the toddler age group, we find the incidence to be 38%. and in the adolescent cohort can be up to 19%. These cytogenetics tend to mirror the adult cohort. Most commonly occurring is a complex karyotype, followed by del7q, del5q, and overall has a poor prognostication. So just with reference to the South African perspective, and I'd like to acknowledge Dr. Vaughan and Dr. Hodgkinson. This particular study was published last year, and it's from Chris Hani Baragwanath Hospital in Johannesburg. And the study looked at 277 patients with AML, of which 160 were classifiable based on cytogenetics, and unfortunately 87 had no molecular classification. So the findings of the study, particular reference to AML myelodysplasia related, was the incidence between the age of 50 to 60 years was 17%, and as the patients got older over the age of 60, the incidence was up to 47%, and this is aligned with global trends. The median age, however, was 54 years, and this is much younger than what the global trends predict. The conclusion of the study, however, was there is an underestimation of AML myelodysplasia related. This is possibly due to the fact that we don't always test for somatic mutations, and often the cytogenetics do fail. So how do we unleash the pathobiology? The mechanism in terms of progression from MDS to AML is not fully elucidated, but it's postulated to be related to the bone marrow microenvironment, including the balance of angiogenesis, the pro-inflammatory milieu, and the fibrosis, which we appreciated in case 2. However, the pathophysiology, or rather the pathobiology, is driven by the molecular aberrancies. The first is unbalanced cytogenetics, where we have abnormalities in deletion 5q, and that's associated with the loss of tumor suppressant gene NPM1. del7q is associated with the loss of RUNX1, which impairs differentiation, and we all know 17p abnormalities cause genomic instability. With reference to the somatic mutations, as I mentioned, TP53 causes a loss of tumor suppression. RUNX1 is associated with impaired cellular differentiation. And then we have the epigenetic regulators, which include TNMT3A, TET2, and EZH2. The SF3B1 and U2A form part of the spliceosome machinery, and there might also be abnormalities in FLT3 and RAS, which form part of our signal transduction pathways. So generally, in terms of the development of AML, the first type of mutation would be an epigenetic one, followed by a secondary mutation, which often involves signal transduction or tumor suppression, involving 1 and TP53. Silent but violent, how do we catch the clinical manifestations before the boom? There might be a prior history in terms of cytotoxic or radiotherapy, and this might help to tease out the differential of therapy-related AML. One must always inquire about a family history because of the germline propensity, and inquire as to whether there's a history of MDS or MDS-MPN overlap. There's no specific clinical manifestations, but one might present with symptoms relating to the pancytopenia. So how low do we go in terms of the pancytopenia? And later on, we're going to discuss the differential diagnosis for pancytopenia in acute myeloid leukemia. But in terms of the cytopenias, generally the white cell count is around about 7, but can range between 0.3 to 375. The hemoglobin is a moderate anemia of about 7.1, but might range between 3 to 14. And the platelet count is a grade 3 according to the WHO classification, however, can range between 1 and 458, which is normal. Generally, this entity has a poor prognosis with a lower remission rate and shorter overall survival. But just to highlight that there is a worse prognosis with the category of MDS defining cytogenetics and MDS-related mutations. So what further contributes to a poor prognosis in an already poorly defined disease? So the ELN, according to the 22 updates, suggested that this particular entity falls into adverse prognostication, but those who are younger performed better than the elderly with a comparable relapse rates. Patients with more than 2 mutations, particularly involving TP53, conferred significantly poorer. And we can appreciate this with figure C, this Kaplan-Meier graph on the right, highlighting in gray that those with more than 2 mutations conferred poorly. Those with a complex karyotype predicted a lower response, and often the complex karyotype is associated with TP53 mutations. And interestingly, those pre-treated with hypomethylating agents were associated with lower overall survival. Once again, in terms of the ELN risk stratification, both our patients, the first case of translocation 6-9, which is the DECNUP 214, as well as the patient with the MDS-related mutations, fell into the adverse prognostication. So how do we decode the blast? What are the investigational approaches that we would employ? After conducting a detailed clinical analysis and history, one would progress to a peripheral blood smear where one would encounter a pancytopenia. Just to note that in the younger population, they might have a lower white cell count, lower blast count, and a lower LDH. Then on analysis of the peripheral blood smear, there are degrees of dysgranulopoiesis or dysgranulopoiesis noted by hypogranular, hypolobated as well as analysis of the blasts. With reference to the blasts, if one notes single tapered hour rods present in the blasts, this can often help to tease out the differential diagnosis of translocation 821, which also presents with dysplasia. One might encounter dysplastic platelets noted by large hypergranular platelets, red cell anisopoikilocytosis, and nuclear budding. Similarly, the bone marrow might demonstrate more than 50% dysplasia in 2 myeloid lineages, but just to highlight that one needs to have 20% bone marrow blasts or peripheral blood cell blasts. So the dysgranulopoiesis can be small or unusually sized neutrophils, nuclear hyposegmentation or pseudopellurized neutrophils. So figure H highlights a pseudopellurized neutrophil, which is also hypogranular. Nuclear hyposegmentation, decreased or granules or agranularity, pseudo-Shigeaki-Gashi granules, Dolly bodies, and hour rods. The hour rods can be present either in the neutrophil or in the blasts or the blasts. And dyserythropoiesis is also quite striking, and this was noted in both case 1 and 2, where there's nuclear budding, internuclear bridging, karyohexis, multinuclearity, megaloblastoid change, ring sideroblast, vacuolization. And the dysmegakaryopoiesis, also noted in both cases, might reference to micromegakaryocytes, nuclear separation or hyperlobation, and multinuclearity. With respect to the flow cytometry, dysplastic features can also be noted by the demonstration of reduced side and forward scatter, aberrant differentiation patterns, loss of hematogones, aberrant CD56, CD7, and in the first case demonstrated, for example, CD9, CD15, which is a maturation marker. The blast counterpart might also demonstrate aberrant immunophenotypic expression of the immature markers CD34, 117, and HLA-DR, and variant myeloid differentiation markers, for example, MPO, CD13, and aberrancies in the maturing monocytes or even in the erythroid immunophenotype. Interestingly, a complex karyotype is the most common cytogenetic abnormality, followed by DEL7Q and DEL5Q. It is very infrequent to note balanced translocation abnormalities. Okay, with reference to the somatic mutations, the MDS defining mutations, just go back. I just want to check if everyone can see my slides again.
We can, Jasmine.
Okay. With reference to the MDS defining mutations, more than 95% or the ICC defines more than 95% specificity of 9 specific mutations. So the following mutations would be the splicing factors, the chromatin modifiers, and the cohesion complex, which is STAG2. Interestingly, the ICC placed a lot of focus on RUNX1, which was MDS defining. However, the WHO5 did not mention the specification of RUNX1. In the younger cohort, FLT3, NPM1, and DNMT3A can be found. And in the elderly cohort, TET2, ASXL, RUNX1 are most commonly found. Also, in the older population, more than one MDS-related mutation is commonly found. But however, both groups confer an unfavorable prognostication. So this particular schematic highlights the difference in gene mutations in relation to the age. So in the salmon pink color, this highlights essentially the young cohort, and in the Pacific blue, this signifies the older populations. And we see the aqua signifies the adverse mutations associated. So we have often more adverse mutations with the elderly population, specifically ASXL, RUNX1, and TET2. So how do we navigate the diagnostic minefield? Essentially, when entertaining a diagnosis of MDS with AML, we want to tease out the following differential diagnosis. For example, therapy-related AML. And some of the discerning features would be they do have dysplasia. The patient might have a previous exposure to topoisomerase 2 inhibitors or alkylating agents, and often there's a TP53 associated mutation. The diagnosis of CMML might also be a differential with AML and dysplasia, particularly CMML transformed. This particular entity is found in the older male. There's always a monocytosis with an absolute monocyte count of more than 1, and often have the association of somatic mutations TET2, SRSF2, ASXL, and trisomy 8. And there's an aberrant monocytic immunophenotype that's associated. What about MDS excess blasts? That's also a differential of the presence of blasts with dysplasia, often found in the older male with less than 20% blasts, and have the presence of the somatic mutations SF3B1 or U2AF and RUNX1, and have an aberrant immunophenotypic expression of the blasts, which include CD5 and CD7. 821 also presents with dysplasia and an increase in blasts. Remember that recurrent genetic abnormalities do not need to entertain the diagnosis of having more than 20% blasts, but the background cells might include in eosinophilia, basophilia, an increase in mast cells, might be an associated c-KIT mutation, and the blasts morphologically demonstrate a single tapered hour rod, and the immunophenotypic expression of these blasts might also demonstrate an aberrant B-cell immunophenotype. Just to highlight that AML DEC 214, which is the translocation 69, also presents with a pancytopenia dysplasia and aberrant immunophenotypic expression. Just to note that one must always exclude reactive causes for dysplasia in the background of an acute myeloid leukemia, and to make sure that it's not clonal cause of the dysplasia. So some of the reactive causes that we might want to exclude include infections such as HIV, states of inflammation, environmental causes, nutritional deficiencies, copper and B12 deficiencies, certain medications, and other congenital associations. So really these two cases highlight two big differential diagnoses. And I think as a pathology registrar, these sort of tables and lists become so useful when teasing out differential diagnosis for AML with dysplasia and AML with associated pancytopenia. Interestingly, both AML with myelodysplasia related changes fall into both entities, but other differential diagnoses for dysplasia associated with AML include an erythroid leukemia, therapy-related AML, CMML transformed, MDS transformed, RUNX1, RUNX1T1, so that's your translocation 821, DECNUP214, which is translocation 69, and always reactive causes in the background of an acute myeloid leukemia. Some of the differential diagnoses for AML with a pancytopenia include acute promyelocytic leukemia, hypercellular AML, hypercellular MDS transformed, aplastic anemia transformed, and myeloproliferative neoplasm, particularly myelofibrosis, the DECNUP214, and our M7s. So how do we decode the bomb? Essentially, diffusing the bomb is achieved through a nuanced therapeutic algorithm, and this must integrate the patient's goals of care, the comorbidities, disease characteristics, so looking at the mutational profile, and the availability of targeted treatment, and of course, transplant. So the first thing is to assess the fitness of intensive chemo in terms of the patient. What are their comorbidities, the past medical history? What prior cytotoxic treatment have they received? What are their cytogenetics and molecular risk and their measurable residual disease status, as well as is there a donor availability? And of course, what's the patient's goals and preferences? So in terms of treatment, we would want to start with induction with 7+3, followed by an early allogeneic stem cell transplant after the first CR. We can also employ the utility of chemotherapy, hypomethylating agents such as azacitidine. I'm going to discuss this as well with or without venetoclax, which is our BCL2 inhibitor. So in a newly diagnosed patient with AML, first, we would want to assess the eligibility for intensive induction. And ultimately, the goal is, and according to the literature, is to give these patients liposomal daunorubicin and cytarabine with a hypomethylating agent and venetoclax. Then one would assess their response based on the flow cytometry, PCR, and NGS. And if in remission, one would then assess the eligibility for transplant. So just a little bit about daunorubicin. It is dosed at 60 to 90 milligrams, and this is the 3 and the 3+7. Cytarabine is 100 to 200 milligrams per meter squared for 7 days. But other regimes that we could use, and we have within Albert Luthuli, we have FLAG-IDA as well. In terms of the daunorubicin dosing, yes, it can be given 60 to 90 milligrams, but according to the literature, it is more efficacious to give 45 milligrams per meter squared in the elderly, as this lowers the toxicity profile and improves the overall survival. According to the literature, there really is no difference in the utility of 60 versus 90 milligrams per meter squared. The literature also talks about gemtuzumab ozogamicin or Mylotarg in use with standard 3+7 induction. And the literature has used fractionated doses of 3 milligrams per meter squared. And the utility of this is to reduce the toxicity profile. But Mylotarg was used to be more efficacious in the female cohort, those under the age of 70 that are non-FLT3 ITD mutated, and was shown to be beneficial in standard risk or intermediate risk AML. So therefore, we question the utility of Mylotarg in AML with myelodysplasia-related changes. And then what about our FLT3 inhibitors? Midostaurin, according to the ratified trial, was efficacious in combination with 3+7 in patients between the ages of 18 to 16 with FLT3 mutated disease. What about liposomal daunorubicin and cytarabine? So the literature speaks of this particular drug being more efficacious in that it has a unique formulation which delivers a greater drug to the tissue. It was approved in 2017 for both therapy-related AML and AML with myelodysplasia-related changes, and has improved the remission rate with a longer median overall survival. However, has similar toxicity profiles to the standard 3+7. However, the liposomal formulation has a longer time to neutrophil and platelet recovery of about 35 days, and shown to be a similar efficacy compared to the hypermethylating agent azacitidine and venetoclax. And this was proven by a phase 3 randomized control trial, which was open label, comparing the hypermethylating agent and venetoclax compared to the liposomal formulation. And they found that in the study, the liposomal formulation patients receiving that had a longer hospitalization and more episodes of febrile neutropenia, possibly due to the delayed fact that the neutrophils tended to recover much later. So what about the hypomethylating agents? They are the cornerstone of therapy in particularly the elderly, and decitabine is inferior to azacitidine. In terms of its administration, it is given on 5 consecutive days every 4 weeks, but as I said, it's not as efficacious as azacitidine. So azacitidine was proven to be efficacious in a randomized controlled trial titled AZA-AML 001, and they compared its utility with 7+3 as well as low-dose MRC. And they proved that azacitidine in combination with the standard chemo was more efficacious and had an improved overall survival in these patients. But genetics did play a role, as those patients with AML MDS-related mutations did worse. However, in combination with azacitidine showed an improved overall survival. And then just a little bit about our BCL2 inhibitor, venetoclax. It is a BH3 mimetic, which inhibits apoptosis, and its indication is in newly diagnosed elderly patients with AML over the age of 75, those patients who are intolerable to intensive chemo, and those patients, venetoclax can be used in combination with low-dose MRC because it has been shown to be synergistic. It can also be used as monotherapy, but has been shown to be more efficacious with FLAG-IDA or 3+7 and cladribine, as I mentioned, due to its synergistic effect. Some of the toxicities include myelosuppression, gastrointestinal toxicities, tumor lysis syndrome, and it is a CYP3A4 inducer, so one needs to be mindful of the concomitant use with azoles. So just looking at the aftermath, what happens post-remission? Post-induction therapy is rather necessary to improve and ensure a favorable and long-term outcome. So the ELN recommend that in intermediate and high-risk categories, one needs to consolidate with a matched related allogeneic stem cell transplant and either maintain with sorafenib or a hypomethylating agent and venetoclax. So just looking at transplant, is there a role? What are the outcomes? And when is it recommended? Transplant is noted in this particular entity as the great equalizer, as it is advised in all patients with a curative intent. So just looking at the literature, a single institution study in Japan looked at the overall survival, the non-relapse mortality, and the cumulative incidence of relapse, and compared AML versus AML with myelodysplasia-related changes after transplant, and found that there was no difference really. AML myelodysplasia-related was not an independent poor prognostic factor after allogeneic stem cell transplant. So they noted that allogeneic stem cell transplant tends to offset the poor prognostic factors of AML myelodysplasia-related. When would a transplant be recommended? Generally after the first CR, which improves a better overall survival and event-free survival. So what do we do in the elderly cohort in patients over the age of 75, as those patients with AML myelodysplasia related will be over the age of 75? The backbone of therapy seems to be the hypomethylating agents azacitidine in combination with venetoclax. But if one has a TP53 mutation, investigational approaches such as glastiglib, which is a hedgehog pathway inhibitor, is a palliative or rather a feasible option. Then what one would assess for MRD based on flow, PCR, and NGS, and then would assess for transplant eligibility as well. In cases of relapse refractory AML, one needs to employ rather targeted approaches. So the utility of, for example, ivosidenib if the patient has an IDH1 or 2 mutation in combination with azacitidine and venetoclax, or gitaretinib if the patient has a FLT3 inhibitor with azacitidine and venetoclax. And if the patient does not have a targetable mutation, one could employ the utility of standard chemotherapy. So in our setting, we have MEC, we have FLAG-IDA. Mylotarg can also be used in combination with azacitidine and venetoclax. And once again, investigational options for TP53 mutation. Then one would assess measurable residual disease with flow PCR and NGS, and assess once again transplant eligibility. If the patient has already had an allogeneic stem cell transplant, one would consider the utility of stimulating graft versus leukemic effect through DLI, donor lymphocyte infusion, or immune checkpoint inhibitors, or consider a secondary allogeneic stem cell transplant. Unfortunately, at Albert Lutuli, we have the option to offer our patients those therapeutic modalities. So what might potentiate therapeutic challenges in our patients? The first is the advanced age. Often these patients have comorbidities, poor ECOG performance statuses. So therefore, these might be challenges when considering drug and therapeutic options. Also, the prior treatment history. Patients who've been treated with hypomethylating agents have an increase in cytotoxic T lymphocyte protein 4, which causes resistance to further therapies. And of course, this goes without saying, the availability of treatment is a challenge for us all. So lastly, I want to just talk about battling two fronts, AML in pregnancy, as both of our cases presented with pregnancy. And often, in my experience, we've had many patients with leukemia presenting early second trimester or even late in pregnancy. The incidence of leukemia in pregnancy is 1 in 10,000, and one needs to have that multidisciplinary approach that we also employed in our cases. So this is the combination of using the utility of a geneticist, obstetrician, the family planning, neonatologist, and of course us hematologists. Just to note that pregnancy on its own affects drug metabolism, and this is through plasma volume distribution, but also just to note that specific cytotoxic have different molecular weights, and those that have a molecular weight less than 400 kilodelta tend to cross the placenta and affect the fetus more readily. For example, the antimetabolites are most teratogenic, followed by the anthracyclines. Interestingly, they have a molecular weight of more than 500, so don't readily cross the placenta. Just to note that the topoisomerase 2 inhibitors might also cause MLL rearrangements in the fetus as well. In the first trimester, the risk of teratogenicity is about 10 to 20%, and this is because chemo causes irreversible damage to organogenesis. In trimester 2 and 3, the cytotoxic particularly affect the growth of the fetus, and this is because chemotherapy inhibits trophoblastic proliferation, coupled with impaired maternal nutrition, causes a risk of intrauterine growth retardation, preterm deliveries, and of course, fetal death. There's also a risk of cytopenias in the third trimester, so one needs to be mindful of balancing the utility of cytotoxics and of course the development of cytopenias closer to delivery. Interestingly, daunorubicin and cytarabine can be introduced in the third trimester, but one needs to be mindful of regular surveillance and fetal cardiac monitoring. So after we've administered cytotoxic to a pregnant female, invariably they will develop sepsis. So just to note that certain antibiotics are contraindicated in pregnancy, for example, sulfonamides, tetracyclines, azoles, as little as 400 milligrams in the first trimester of the azoles has particularly been shown to cause hyperplasia of the nasal bones, short thumbs, cleft lip palates, etc. And then lastly, just to be mindful of breastfeeding. So certain cytotoxics will cross and enter into the breast milk and, of course, have a fetal affectation. Atra does cause fetal arrhythmias, and Ciprobe, and the antibiotic Ciprobe, has been known to be excreted into the breast milk and causes a pseudomembranous colitis as well as cartilage erosion. And then lastly, we had to be mindful of the use of cytotoxics post cesarean section, and just to be mindful of the fact that it can cause wound dehiscence and breakdown. So dropping bombs, where essentially are we heading to and where are we going? The future directive therapy includes multiple clinical trials, particularly involving liposomal daunorubicin and cytarabine and its utility in those under the age of 60, as well as the use of liposomal daunorubicin and cytarabine with the oral hedgehog inhibitors gastaglip, and of course geriatric options, which include either the utility of standard 3+7, the liposomal formulations, hypermethylating agents and venetoclax, or azacitidine alone and low-dose Ara-C. So in conclusion, and my parting remarks is that AML myelodysplasia related is a ticking time bomb. It's highly aggressive and it's associated with poorer outcomes, but don't write these patients off just yet, because AML with myelodysplasia just morphologically confers a better prognostication than AML myelodysplasia with adverse mutations in cytogenetics. The liposomal formulations are approved and are conducted in certain trials in progress, but the aim really is for allogeneic stem cell transplant with a curative intent. Future studies are still being done to address the subtype, so the spark is lit, and this is really only the beginning of our explosive discussion. So I'd like to just end off with a quote from Malala, building from the rubble and remnants, is that you don't make a country strong by destroying others, but rather you make it strong by investing in education. And I hope that this has been just that, enlightening and educational, investing in the growth of our hematology society. So thank you to Blood SA for this opportunity to present, as well as to our team of bombshells and firecrackers, and of course to you for your attention this afternoon. Thanks.
Thank you, Jasmine, for that really, really in-depth and excellent presentation. I think you made a very complex topic understandable. And I just want to make a few comments before we open. There are no questions at the moment, but you know, the reason why we decided to present these two cases, firstly, they were young ladies who were pregnant, and they were quite a challenge to manage. Unfortunately, the one we had to, well, she opted for palliation. And I think that the positive of this entire two cases is that we were able to successfully deliver the babies, and they are doing well. I think for us, it is the challenge of getting the genetic testing, you know, the delays with NGS and the molecular studies, which often are released once we've completed the patient's chemotherapy, and we only really get to understand what is going on with our patients when we actually get these. And having treated patients for a long time, I realized that, you know, over the years, we probably were dealing with a lot of these cases where we were not able to actually identify why these patients were doing so badly. And I think it's giving us more insight with next generation sequencing as what is actually happening in our population. So it has added a huge value to our, our diagnostic panels that we are using now. Another interesting thing which I just wanted to mention for the maybe if there's some junior registrars that are on here, is that Jasmine did mention the B12 deficiency, which can mimic MDS like changes. So oftentimes patients you would receive these slides. So it's important to be able to have a high index of suspicion as to whether this is actually a malignancy, or are we dealing with a nutritional deficiency, and correct for the deficiency. And if it corrects, then you know that it is a nutritional cause. However, in these cases, it was quite obvious that these patients actually had circulating blasts, so it made it easier. With regards to treatment options, obviously in state we are limited. I mean, it would have helped to actually, for case one, I think if we had access to the hypomethylating agents in venetoclax, perhaps with this patient having a matched sibling donor, that we could have gotten her into a better state with those agents and then transplanted her. One might ask why, if she had a low blast MRD on the flow, why did we not proceed? Our experience is, whilst planning for these patients' transplant, because it obviously takes a while, the disease gets worse. And if you do not have agents that can actually target the aggressiveness of this disease, it actually becomes a futile attempt. We end up utilizing a large amount of resources only to palliate the patient at the end. I think where we actually could improve on the way we're managing these patients is if these agents could be added on to the essential medicines list for specific patients. So yeah, I will end there. Let's see, there's a few comments. Jasmine Baby Chapter says, thank you, very well presented. Lynette, it was very informative presentation, interesting cases. Lee is wondering how many such cases we have missed at lower level hospital by rushing to transfuse anemic pregnant patients without investigations. A really, really important point, Lynette, is that it's important to have the smears reviewed. And actually, if you are worried that these cases actually should be discussed for escalation to a higher center for further investigation. Fortunately, these two patients made it to us, but I'm sure there are people being missed. Estelle asked, are you doing NGS in all cases? AML? Yes, Estelle. All our AML patients now are getting NGS. So
do you have an idea how many you have per year? Because elderly AML may not always come to you. They may stay at King Edward, or they may stay in the regional hospitals.
Yes, so so what we do is that if these patients are not eligible for treatment, we do not marrow them and do not invest our resource. But if the patients are in a good, just say it's a borderline sort of age, and they have a good performance status, perhaps we in that, say they are 58 or 59, we may consider going the whole hog and actually doing a bone marrow and doing the flow, etc. In some cases where we are suspecting it's an AML that has transformed from an underlying CML, we might run a few tests and then start a TKI. But the older patients are a bit of a challenge, and we have to obviously manage our resources. We've overspent our budget already, and as much as for academic purposes, it would be good to be able to actually define our elderly population. I think that it's an important thing that we actually are missing, in view of the fact that we have access to, in South Africa, hypomethylating agents and venetoclax, whether the fitter older patients are getting sort of a raw deal. That's my feeling, but obviously, we have a lot of patients to manage with the little budget that we have. Maybe if things improve, we could actually do more for our older patients.
Yeah, so that's debatable. I don't know. It would be nice, but I think if we could do more for our younger patients, I would be happy already. If I can make the bombshell of or what did Jasmine call it? The nuclear option of no, it was something more positive of doing a transplant. What was it, Jasmine? I mean, it's I have many opinions, and I don't know. Just one thing, I don't know if there's any from the other units, the academic units. I don't necessarily think that there will be many people from private, but the question is, what is a treatable age in academic units? We find that our patients are very, at Groote Schuur, they are very, very difficult to treat after the age of 50. Honestly, it's just not, they are not biologically 50. So for us, we would probably think very deeply, unless we take somebody very fit, very medium risk type of AML, that type, intermediate type. So I don't know if there's other opinions. I just would like to know if there's any other opinions.
So Estelle, what I think, I cannot say this is the case, but I think now that we have next generation sequencing, we actually possibly are going to be diagnosing more younger patients, because this is like our third patient, first, second, and third. There was a young patient that we actually presented at as a poster in one of the conferences, where this was a young boy with also myelodysplastic related changes, and now these two young patients. So my feeling is that we have been missing these young patients. As Jasmine said previously, we only had molecular and FISH, and we were testing for recurrent genetic abnormalities if the patients had features on the bone marrow. And I think we are now seeing something different. And perhaps as time evolves, we will start to define this population of younger patients in South Africa. And I think it will probably give us a more I guess more patients will be added to this, because this is just our experience now. I would say in a 2-year period, we've had 3 young patients, and I don't know how many others have been missed. So as you said, it's the younger patients that we need to focus on. And interestingly, the patient with the RUNX1, with the germline predisposition, there was somebody that spoke last year, and they were wanting to do some work with us about testing for germline mutations. I think this would be one case that I actually would like to add to. They were supposed to come. I don't know if you remember, Estelle, we did speak about it on one of the platforms. There was a group, I think it was from the US, that actually spoke to us.
I remember that, yeah.
Yeah.
But
So
it didn't,
it didn't
get very
materialize.
far.
Yeah. So, I mean, there is these patients that it would be good to actually define. And yeah. So I
Yes.
don't see any more questions. I don't know if anybody else wants to comment on their experience in the private sector, perhaps those of you that have access to the hypomethylating agent venetoclax, and whether you've treated any patients with myelodysplastic related changes in the younger population, and what your outcomes has been. I don't see any hands up.
Sounds like you have stunned us with your bombshell revelations. I just want to say, for photos of the unit, you guys are always tops. Fantastic. Well done.
Thanks, Estelle.
Thanks,
It was lovely talks. Everybody was very impressed. Thank you very much, as always.
Thank you so much. And thank you everybody for tuning in. I think Dr. McDonald, I'm sorry, Khardine, I didn't remember
it's Andrew
McDonald.
for next week. Yeah.
Yes.
And it is about ALL and blinatumomab and all those wonderful things. And hopefully we'll have some pediatricians joining us. So it's for a nice, robust discussion on best treatment in AML, ALL, which has really become a real star. It's with modern treatments, these patients are doing so much better.
thank you, Estelle, and thank you to your team. Thank you, Jasmine, and to our audience. Thank you for listening in this afternoon. Have a good afternoon. We'll see you next week. Bye.
Thank you so much, Shalene. Good afternoon, everybody.
Bye-bye.